And I'll start at 7, right?
I'm going to recording. All right, so let's just do a little housekeeping and welcome first. So good evening, everybody, and welcome to the Lupus Foundation of America Chapter Network's Let's Talk About It webinar series. My name is Cindy Meserly, and I am the CEO of the Lupus Foundation of America Philadelphia Tri-State Chapter. We represent Pennsylvania, South Jersey, and Delaware. So welcome to all of our tri-state peeps and from everyone around the country, because it's so fun to see everybody. Each month, the Chapter Network gathers together for this Let's Talk About It program to discuss important topics related to lupus from experts across the country. And tonight we will be discussing lupus in the skin with our local expert and national expert, Dr. Victoria Worth. Before I introduce our presenter, I just want to remind everybody the information provided in this webinar is for general information and educational purposes only, and it is not a substitute for your physician's advice. The views expressed by our webinar presenter are those of the presenter and not necessarily those of the Lupus Foundation of America. Tonight's webinar is being recorded and will be available through your local chapter shortly following the program. And if you have any questions during the program, please type them, put them in the chat or the Q&A, and we'll get to as many questions as we can throughout the program. Please do note we cannot address specific diagnostic or treatment questions, and you really should contact your physician directly following this program if you do have very specific questions that certainly may come up as the content is presented. If you do have further questions unrelated to tonight's program or topic and want to learn more about lupus programming and events in your area, please reach out to your local chapter, or you can certainly reach out to us directly in Philadelphia at info@lupustristate.org, and we'll put that in the chat for you all. So now I'm really excited to introduce a great friend to our chapter, our speaker for tonight's program, Dr. Victoria Worth. Dr. Worth is a professor of dermatology and medicine at the University of Pennsylvania School of Medicine and chief of division of dermatology at the Philadelphia Veterans Administration Hospital. Dr. Worth earned her medical degree at Johns Hopkins University School of Medicine in Baltimore, Maryland. She completed a residency in internal medicine at Northwestern Memorial Hospital in Chicago, Illinois, and dermatology residence and immunodermatology fellowship at New York University School of Medicine in New York. She joined the faculty at the University of Pennsylvania in 1989 and has developed an internationally recognized program in autoimmune skin diseases. Dr. Worth is also a member of the Lupus Foundation of America's Medical Scientific Advisory Council. We're extremely grateful for all of the incredible work you do, Dr. Worth, at the national and local level. Thank you for being with us tonight. And with that, I will turn it over to you.
Well, thank you very much, and it's great to be here. And I have to say, one of the advantages, I guess, of Zoom is that we can be together even if we're in different parts of the country, and I think that's really neat. So I'm going to just go over some of the different subtypes of lupus and then talk a little bit about treatment and some new developments. I have conflicts, and I want you to know these are relatively recent because there's finally getting to be much more interest in finding out how we can do a better job of taking care of the skin in lupus. And so that's kind of important from my perspective. And then also I've been involved with developing an outcome measure called the CLASI that's been used in numerous international trials to look at skin outcomes. So I want to start out by saying that skin lupus is a little complicated because sometimes there are lesions that we call lupus specific, and what those might be would be discoid lupus or subacute cutaneous lupus or acute cutaneous lupus with a butterfly rash. And a biopsy of any of those can look fairly similar and but would be able to be identified as being related to connective tissue disease. Having said that, what's also important to know is that lupus is not the only thing that can give the same biopsy. There are other diseases very close to lupus that can do that as well. So it is important to think as a physician, I have to look at the patient, I have to look at the biopsy, and then I put them together clinically to figure out what's the most likely diagnosis. There are also lupus nonspecific lesions, which means that if you did a biopsy, you wouldn't necessarily think it was lupus, but it can be associated, things like hives, vasculitis, libido, and those are all things that can happen in association with lupus or on their own or with other diseases. So these are the different types of skin lesions that we see most frequently. There's chronic cutaneous lupus, and that is a little bit of a wastebasket, meaning that it includes patients who have discoid lupus, which can either be localized, that would be on basically head above the neck and in the scalp. Generalized means above and below the neck. And then hypertrophic just means that it's a little bit thicker lesions and can look a little different, but basically the treatment and approach is very similar. And those are all lumped together under discoid lupus. And then the next thing down here is lupus paniculatus, inflammation in the fat, and then tumor lupus, which is yet a third type of cutaneous lupus, which again is lumped together under chronic cutaneous. And then subacute cutaneous lupus, it looks more like psoriasis, or it can look almost like annular or polycyclic type lesions. And those are also lesions that we see that are really lupus specific lesions. And then acute LE, which we see in the butterfly rash, or also on the arms and legs or the chest or back, and that's photodistributed erythema. So you can see this is a little bit complicated, and thus it's really helpful, I think, to be able to have this discussion, because I'm sure there'll be other questions that will be coming up. So when
Dr. Worth, sorry, let's do that poll to see the type of
I like
lupus.
that idea.
Yeah, and you'll see who's in the audience out there. So we're going to launch a quick poll to see what type of lupus you have, and maybe you don't have lupus, but take a quick minute and take a look at this. You should all be seeing it. And then we'll share those results momentarily. All right, we're still answering. I'll give you 10 more seconds to answer.
Are you getting some?
All right, yeah, let's go. Let me share these results and everybody will be able to see them.
Okay, yeah, that's right.
That's, yeah, so primarily SLE, a little bit of CLE in there, a little bit of mixed, and some of you who don't have lupus. So we got a little bit of everything out there.
Yeah, but a third of people who have skin kind of predominant potentially, or at least SLE with skin. And so, and so also people with SLE get skin involvement as well, or it might be photosensitive. So I think this is really good, helpful for me to know, who's listening. Great. So when we talk about what the prognostic significance of cutaneous lupus is, it's important to think of it as really a spectrum disease. And, we make it look easy. It's either skin disease, or on the right-hand side, systemic disease. But the reality is it's really a spectrum where many people have skin, but also might meet some criteria for systemic lupus. And it's not so, you can have a little joint inflammation, maybe a little pleuritic chest pain, but have predominantly discoid lupus, paniculitis, or tumid LE. And those are more likely not, people with those manifestations are less likely to have systemic lupus, whereas those who have more generalized above and below the neck discoid lupus or subacute cutaneous lupus are more likely to have some systemic lupus. And then the people who have butterfly rash, acute cutaneous lupus, or what we call these lupus nonspecific lesions, are more likely to have systemic disease. So it really truly is a spectrum. And I'm going to just show you some examples. So this is discoid lupus, where you can appreciate that there's really a lot of characteristics here of erythema. There's dyspigmentation, there's some scarring. And on a biopsy, you can see on the right-hand side, we see typical changes of lupus. And I'm not going to go into that. I don't expect you to become a dermatopathologist, but a biopsy can be helpful in making a diagnosis of an autoimmune problem. You can often see in the ear some discoid lesions, and you can see in the scalp here there's some involvement. So these are very typical areas for discoid lupus. You can lead to changes in pigment. It can be changes in with loss of hair, some of which can be permanent. And so we do like to try to treat early on to see if we can prevent getting this permanent scarring that can happen. But you can see here that this is on the left-hand side, somebody who has, both some activity with the erythema, but also dyspigmentation and scarring, which is part of damage. And so really those can occur together. And on the right hand side, just to show you, this is what the hair follicle looks like under the microscope here. This kind of with the keratin, that's like the hair right in the middle there. So, and this is the blue cells or the inflammation that can happen around the hair follicle. And so we try to get rid of this inflammation, because if it stays there, it can then lead to the kind of damage that will lead to this kind of scarring. So this is kind of one of the things we're trying to target when we do studies to try to improve skin lupus. And then here again, you can see discoid lupus. This time it's generalized, so it's not just on the head and neck, it's also on the trunk and on the back. And so you can see that it can be quite extensive. And there are, again, elements here of some damage, but also lots of activity with the red in the scale and some erosions here. This is a little more hypertrophic, a little more elevated, so still within the chronic cutaneous lupus. This is lupus paniculitis, where you can sometimes get a depression on the skin, and the involvement is down in the fat. So these blue cells are no longer way up here. They're a little bit further down. And that can lead, as it gets better, to sometimes a little dimpling in the skin. And this is kind of a rarer complication. So don't worry that if you have lupus in the skin, it's going to go to this. This is pretty rare, and often this is how it starts, is in terms of being in the fat. And then this is tumid lupus, where the sun is often exacerbated for many types of skin lupus, but in particular for tumid lupus as well. And this doesn't scar, but you can see how it can look a little bit circular. And one of the hallmarks on the biopsy here is this bluish kind of spaghetti looking area, which is called mucin. And that's something we see in autoimmune, like in lupus, but also especially so in tumid lupus. And then you can see lesions in the mouth, which may be painless. It can be painful, or in the nose. These are very common areas for erosions to happen. And so, your doctor might want to be looking in your mouth to see if that's present. And that's typical for any of the subtypes of lupus. So we recently have been trying to figure out, how do we tell the different types of lupus? I've shown you already quite a few things here. How can we tell who has discoid lupus? And it turns out it's mainly based on the damage. So is there scarring? The location can help a little bit, but dyspigmentation counts a lot, or some, but it often, and also the location. So these are all things that we look for, but in particular, the scarring. So if somebody comes early in their disease and they don't have scarring, we may not 100% know what subtype of skin lupus the person has. So then there's subacute cutaneous lupus, which is where you can sometimes get circular lesions or the psoriasis lesions. And this is what it looks like here. So circular areas, or almost like a psoriasis on the chest, and often in sun exposed areas. And here, the important thing we ask about are medications, because it turns out that often people who have subacute cutaneous lupus are on certain medicines. And one of those is the one that's used for heartburn, the PPIs, proton pump inhibitors. And you can get those over the counter. So and we think that people who have SLE, who may need a PPI, but also if you get a lesion like this, you have to think about, well, could it be related to that kind of medication? There's some blood pressure pills, there are other pills that can, and medications that can be triggers for this form of lupus, maybe in a third of patients. And then acute cutaneous lupus is the butterfly rash like this, with sparing usually of the nasolabial fold, but you can see that's pretty intensely erythematous. And then occasionally blisters. This is, again, very rare, usually in more systemic disease, but what you're seeing here is a blister. And that's because there's actually an antibody that circulates around the blood and deposits in the skin right here at the basement membrane, right at the bottom of these stack of blue cells. This is the top layer of skin. And the antibody deposits here and causes the skin to fall apart, and you get these blisters. So we know that skin lupus makes people pretty unhappy. And what this is showing you, the blue is lupus. And you can see that the blue is a high number here relative to some of the other skin conditions. And this is a way of looking at quality of life, which we think is very important. We know that skin lupus makes people feel very unhappy, but it also has symptoms associated with it. People can still function, but especially in the emotional realm, because it's often in areas that are exposed, and also it has impacts on being able to go outside and feeling if you're going to flare your skin. That has a lot of negative impact for people. And you should know that if you feel that way, that you have a lot of company, because this is really showing that with this high score, the quality of life often can be not that great for people with skin lupus. We've also compared skin lupus to other systemic disease, such as congestive heart failure, type 2 diabetes, even recent MI. And what you can see in the yellow here are basically that people with these very serious systemic diseases are actually doing better. They have higher numbers in their quality of life relative to people with cutaneous lupus. And in particular with in the area of social functioning, emotional well-being, mental health. And again, it's for all the obvious reasons that it's just, it's very difficult. If you have a rash or losing hair, it makes people feel really terrible. And so one of my jobs is to try to do the best we can to help people with cutaneous lupus, but also to make people know that we need to do better in the way we manage these patients, because it obviously people with this are not very happy, and we should try to improve our therapies. Now, I should also mention that there's some medications that cause photosensitivity. And this can be true, so if somebody has lupus and you get on one of these drugs, you just have to realize it can sometimes even increase sensitivity more to the skin. So what is the sun? And I wanted to touch briefly on ultraviolet rays, and you can see that there are different types of sun here. Here's UVC, ultraviolet C, and that's actually pretty much blocked out by the ozone layer. So we don't worry so much about that. But it's really ultraviolet B that causes a lot of the problems with when people go in the sun and can trigger some of the reactions. And the reactions to the sun can be either on the skin or it can be systemic. So there's some people who get, flares of their joints or even their kidneys when they go out in the sun. So so even though I'm talking about cutaneous lupus, the sun is important for people with systemic lupus, even if they don't have skin involvement. So UVA is a very broad, you can see it involves a lot of numbers from, basically 400 up to like 390 here. And so this is really actually it starts at 320 up to 390 to 400. And UVA is broken down into UVA 1 and UVA 2. Well, UVA 2 is in the 320 to 340 range, and UVA 1 is the long range. So it's actually the shorter wavelength of UVA that also can cause problems with the sun. And so just blocking UVB isn't even enough. You need to block kind of some of the UVA. And so in order to do that, sometimes the physical blockers are a little bit better at doing that, the titanium dioxide or the zinc oxide, but those, not everybody likes those. And so getting a good broad spectrum sunscreen that will block UVB and some UVA is also, pretty helpful. So in terms of sun protection, you want to do, sun avoidance during peak hours. So I often tell people early morning, late afternoon is fine. It's probably not fine to go and lie on a beach, even though a lot of people really like doing that. And also to realize that when you're under an umbrella on a beach, that about 60% of the sun can bounce off the water or the sand and come under the umbrella and cause problems. And so it's very important to understand, that even though you think you're in the shade, you might not actually be in the shade in terms of the amount of light that can get to you. So wearing sunscreen under umbrella and being outside more early morning, late afternoon will be better for people who know that they are photosensitive or that the sun makes their lupus worse. Now, sun protective clothing is also very, very helpful. And you can, that can be kind of expensive, but some of them come with pretty good SPFs. In other words, they really have good protective factor, and they might even have a rating. And what that allows you to do, and some of them are long sleeve, but pretty not so heavy. And so that might allow you not to have to put on the sunscreen all over your body, but just to wear that on top. And that can really be kind of helpful in some ways. Broad rimmed hats are good. And then another approach is to use this RIT SunGuard laundry treatment UV protectant, which one wash cycle lasts about 20 washings, and that gives you an SPF of 30. The reality is that you probably need more like an SPF of 60 or higher when you have lupus, because although 30 works really well if you're trying to prevent skin cancer, it turns out that, and that blocks probably 97% of the light. It's that other 3% though, for people who have lupus or photosensitivity, that you still need to be able to block even better. And so that's why we think somewhere even 70 to 100 is better in terms of SPF. So another thing to mention is that we do have some patients who have who go and get acrylic nails put on, and they might actually have them placed where they have UV light put there in order to have the acrylic work. Excuse me. And so what you're seeing here is that that light actually can cause lupus in the area that the light is hitting. And so you want to be kind of a little bit careful and probably not go for that kind of treatment if you have lupus. It's another way of getting UVB exposure. And we can talk maybe later about other forms of UVB, but there are many ways of getting exposure that are not necessarily being outside. It can be certain lights that emit ultraviolet light. It's good to have an acrylic cover. You don't want to necessarily be under a fluorescent bulb that's not covered. And those are all some of the aspects to think about. Now, I wanted to mention about sunscreen because there was last year a little bit of discussion about a possible carcinogen that was in some of the sunscreens. And you might be aware of that. And there were certain brands that were of concern. And what I want to tell you is that a lot of them are more the aerosol sunscreens, and those probably don't work as well. And plus, it's not that great to inhale the aerosol. So we do kind of advocate more the creams as probably being a little bit safer, although the FDA did recall these, and they do, and these brands were recalled and now they're checked. But then there was yet another, and so this is just showing you that there were a number of different batches that have been tested, and about a quarter of them had some benzene. Some of them were very low, but others were higher. And so, it's important to realize that was monitored, and, probably, again, better to use the creams. It turned out the problem was more with the gels and sprays and lotions than with creams. And so this is just saying that many of them had some of these batches had pretty low levels of benzene, but others had very high levels. So, again, just to be aware. And there was actually a website that you could go on to see where there were problems in sunscreens. But again, they've been recalled, and I would say the most important thing is to use them in terms of the lupus. And the benzene is not going to be in the creams to any extent. But these are some of the brands to think about here. All right, so that's my lecture about sunscreens. I do,
Dr. Worth, let's do a quick poll about sunscreens and see what our audience is doing regarding sunscreens. So we just launched that. So take a moment, tell us how you use sunscreen. Are you doing it every day, most days, some days, rarely? What is sun protection? Ooh, we're kind of balanced here as people are responding. We'll give you a couple more seconds to respond. All right, let's share these results. Lots of sunscreen use happening, not every day, but certainly frequently.
That's good news. I'm always happy to see that because it really is important in terms of controlling the symptoms of lupus and cutaneous lupus. So here, basically we've talked about the sunscreens and avoiding the sun rather in sun protective clothing. Sometimes heat can be a trigger, so you may have to be careful about that. And the medications we talked about as well. So what do we do for treatment? Well, the most common thing we'll think about is some topical steroids, and there's some that are prescription drugs that we have to use. There are also some topical nonsteroidal T-cell inhibitors, such as tacrolimus and pimecrolimus, which can be used, and those are safe on the face. As opposed to topical steroids that we don't like to use so much on the face, these can be helpful. So, they may be something you could think about if you're having problems with lesions on the face. In the scalps and other areas, you may sometimes use injections of steroids, and that can help decrease the inflammation as well. And I noticed that there was a question about, if an area of the scalp is biopsied and doesn't show activity, will the findings be helpful in diagnosis? And so if you don't have inflammation, maybe you had some treatment and it's no longer active, the biopsy will show scar, and sometimes it will be helpful if there's a little bit of inflammation left in terms of being able to tell what the cause of the scar is, but it may not be 100%. And then there was another question about what are some treatments for hair loss other than topical steroids and Plaquenil. And so, the injections we were just talking about can be very, very helpful. And then we'll talk later about the treatments for lupus, which can help hair loss if there's still inflammation there. Unfortunately, if there's scarring, then very often one would have to go on to more hair, either a wig or some kind of weave. And there are a lot of really amazing wigs now that can be used that I can't even tell when people are using them. And so I think that's one of the things, is not to be necessarily worried about using them, because the technology in terms of how they look is getting quite amazing. So in terms of treatment, then we've talked about the injections of steroids, and I can tell you people get really tired of topicals. So this is showing you that if somebody prescribes a topical, they start out using it, but pretty quickly, the use kind of drops down a lot and stays down. And it's not just because they're doing better, but because it just gets tiresome to put on all these creams. And so, there's a need for getting to treatments that people can want to be on for longer. We do know that if you're careful about the sun, then your vitamin D levels are going to be lower. And so it is good, probably, if you are really careful about the sun, to take some vitamin D replacement. We know that people with lupus, if they're careful in the summer, their vitamin D levels are still low relative and similar to the winter. Whereas if you look at other people in the summer, of course, their vitamin D levels go up. And so some kind of replacement vitamin D, if you're really diligent, and drinking milk, or just making sure you get vitamin D could be helpful. And your doctor could check a vitamin D level in your blood to see if it's low. So in terms of what do you do now if you don't want to use the creams and the injections or topicals aren't working? So the first step would be antimalarials, and that is typically hydroxychloroquine or Plaquenil. So we know that about 55%, maybe half of people who need to go on hydroxychloroquine get improvement, and that's not as much as we would like. So this is telling us that we need better treatments, and we often have to advance to other treatments. And so one thing to say, though, is sometimes if the blood level of hydroxychloroquine is low, then it's not going to work as well. There's more treatment failures when it's low relative to higher, where you can get more of a complete response. So missing hydroxychloroquine, once in a while is not going to help get better control. And some people don't take it at all. When we look at studies that have actually measured hydroxychloroquine levels in the blood, it's often found that their levels are really low. And that's telling us that people really are not taking it. And there's a lot of reasons not to take it. But the problem is, if you're not taking it, then your doctor might think it's not working and that they have to advance to other therapies, and that would not necessarily be needed. So it is important to take it to make sure that it's not working. And then again, here saying that is, 10% might even be low in terms of where the hydroxychloroquine levels in the blood are low. So we did do some work that with a drug called quinacrine, which is another antimalarial. And when we added it to hydroxychloroquine, we found that people who didn't respond to hydroxychloroquine, quite a few people did get better with it. Unfortunately, right now, it can only be gotten from a few places as a compounded drug, but it actually does work for some people. And that if you can take that and get that, it may prevent you having to move on to other therapies that require more monitoring. So this is just showing you a study we had done where people at time 0 went on quinacrine, and these were people who were already on hydroxychloroquine, but we added quinacrine. And you can see the responders. This is looking at their skin score coming down. They got better. And even the people who didn't get better by our definition of improvement were trending down. And so it was kind of nice that to demonstrate this way that quinacrine could help. So we know that smoking is really not good. And so we know that the people who smoke are more likely to get lupus and also to have bad cutaneous lupus. So if you smoke and you have skin lupus, it's a great idea to try to stop. And we have really shown now, we did a study at one point showing that the levels of a bad cutaneous lupus are higher in smokers than in people who didn't smoke. And then patients who have discoid lupus above and below the neck are less likely to respond to our therapies than people with localized discoid lupus or subacute cutaneous lupus. but smokers were more refractory to all treatments. And so that's, of interest, and it suggests that there's something about smoking that may be triggering some problems. So what about eye exams? Well, we do recommend getting eye exams at the beginning of starting hydroxychloroquine, and then once a year. I mean, the guidelines now say every, not for 5 years, and then every year after that. It's really hard to remember 5 years. And so, I think it's okay to go every year and get a visual feel to make sure that there's no side effects on the eyes from the antimalarial. If you're on chloroquine, and chloroquine can sometimes work differently than hydroxychloroquine, and it may help in where the hydroxychloroquine did not work. However, it has more eye problems, and so you really have to get eye exams more frequently. Quinaquine doesn't seem to have eye toxicity, which is great. And we never recommend combining hydroxychloroquine with chloroquine because of additive eye toxicity. So immunosuppressives are sort of the next line of therapy. So if the antimalarials don't work, we may have to move on to immunosuppressives. And this includes azathioprine, methotrexate, mycophenolate. And these do work in about half of people who don't respond to the antimalarials, but there's still people who don't respond to these. And they do require, more monitoring of the bloods to make sure everything's okay. And it can cause probably more side effects, some stomach upset, but it can be quite effective and maybe not needed. So we had done a study just in people in our database who were put on immunosuppressives, and again, 50% of people got better. And we think probably for skin, methotrexate and mycophenolate might work a little bit better than azathioprine, but there really haven't been so many studies that have been done with these. Now, what happens if you have, cutaneous lupus that's not responding to the topicals, the sunscreens, the antimalarials, the immunosuppressives? And so the good news is we do have other approaches for really severe skin lupus. And so that would include thalidomide and derivatives such as lenalidomide. And so we do use those, but not in very many people, but when it's needed. And so it can work very quickly within about 2 weeks. And it works for many different types of skin lupus. And for some people with one of the subtypes, subacutaneous lupus, you might even be able to stop it, and much of the time it won't come back. Whereas with discoid lupus, it often comes back and you can just go back on it. But it has a lot of side effects. First off, it's very expensive, so it can be hard to get. But the main one I worry about is a peripheral neuropathy with numbness in the hands and feet. And it can also cause, some clotting kinds of things, and in particular, teratogenicity. So there's no way you can get pregnant if you take this drug because it causes really severe mutations, genetic abnormalities in the children. So you have to be very careful, and there's a whole regimen for making sure that doesn't happen. But people who have to take it, this is the kind of response you can get. This is before and after. And so it's obviously can work. And this is somebody where, the usual approaches we just talked about with the antimalarials and the immunosuppressives didn't work. So the thalidomide analog that we've been using most frequently was lenalidomide. And this is showing you the response. So somebody who didn't respond to anything, and we got them, they were in a trial that we were doing with open label with lenalidomide. And you can see that within 6 weeks, they went from having scale and erythema to being clear. And this is the scar, but blue cells here at baseline before treatment went away on the right-hand side. So this person was very, very happy with their response. And so this is actually being used quite frequently now, but again, for people who really are unresponsive and have really major problems with their lupus. This was another study that came out around the same time. This looked at 15 people who were given lenalidomide, and you can see how quickly the skin got better. I mean, it was pretty amazing. And 86% had a complete response. And so again, for the right person in the right situation, we will use lenalidomide, and it's normally more for discoid or subacute cutaneous lupus. And we haven't used it as much for acute cutaneous lupus. However, we just recently completed a study, a phase 2 trial of a drug called iberdomide, and that turns out to be in the same class of drug as thalidomide and lenalidomide. And it has effects on B cells and T cells, some of the inflammatory cells and monocytes that we think are really could be important in cutaneous lupus. And it's thought to be more potent than thalidomide or lenalidomide. And so this is showing you data, and this is showing you that in fact, when you looked at everybody in the trial, there wasn't really much of an effect in the skin. However, it turned out the people who did better were the people who had either subacute cutaneous lupus, where you can see here that this is what happened to the skin score. It came way down here relative to the low dose of the drug and the placebo. So this worked. And then it also, there was, although not significant with a small number of patients, you can see that the people who got the drug did much better in terms of their discoid lupus than those who got placebo up here. So this is really hopeful that maybe there'll be a drug that'll be approved for lupus that might be helpful for cutaneous lupus. But the thing I wanted to show you is that for acute cutaneous lupus, it didn't work. And so this is really suggesting that there may be some differences between these different subtypes. And it requires one type of drug for maybe some subtypes. And then for acute cutaneous lupus, you need something a little different. So these are some very early studies, but I think it's going to advance our treatments and hopefully lead to FDA approval of drugs for lupus. So, and this is just summarizing what I just showed you, but the idea being that subacute or chronic cutaneous lupus subtypes seem to respond. And it's telling us something about the biology, which a lot of people are studying in terms of the interferons and B cells. So the other approaches to think about, rituximab, belimumab, and belimumab has been around for a long time, and it's being used a lot for SLE. And basically, I will start with the idea that we don't like to use steroids that much, prednisone, for long periods of time for people who have mainly skin lupus. We try to find other alternatives. It may be necessary short term, but long term, we would like to try to find something else just because of the steroid side effects. However, if you have systemic lupus and steroids are needed to control some of the symptoms, then you may end up on a low dose of steroids for a long period of time. And so everybody's a little different, and the management varies. And then rituximab is being used now in systemic lupus for patients who have nephritis, kidney problems. But I would say we don't tend to use it so much for skin. And in fact, we've seen some people get skin lesions for the first time after they got rituximab. And so this is just telling you some of the details of this paper I'm citing down here. But sometimes you need rituximab, but it's important to know that there might be a side effect of getting worsening or new onset skin lupus. So with belimumab, this is the one that I think a lot of people are familiar with because it was really the only new drug in many, many years that came out until very recently. We now have a second new drug for kidneys, but this drug got approved for kidneys pretty recently, but it was being used particularly for joint and sometimes for skin. And so they did a trial that showed that 37% of people had improved when they got this drug versus the placebo, where there was like about 10% lower response rate. And what this is showing you is when you break it down that the rashes did get a little bit better with belimumab, but we don't really know what type of rashes the person had. And we haven't had formal studies for skin lupus. And it also shows that there was some improvement with the arthritis. And so that's another reason why people are frequently given belimumab. Now, what about other new treatments? Because this is going to be an area that's going to be extremely exciting going forward for cutaneous lupus. And we also have a new drug, anifrolumab, that's been approved for systemic lupus, and it worked in skin. And that's going to also be something to think about. And we have more to learn about who it's going to work in. Is it going to work for discoid lupus, subacute cutaneous, or acute cutaneous? We don't yet know. So there's more work to go, but this is very exciting to have another option. And this drug is working by blocking the type 1 interferon, so that the receptor, so they can't bind to the receptor, the interferons, and it dampens down the immune system. There's some newer approaches, one with anti-BDCA2 antibody, and what that does is it blocks the plasmacytoid dendritic cell, which we think is important in many people with cutaneous lupus. And then there are many, many more approaches in the pipeline. So here's anifrolumab in the phase 2 trial, and you can see before and after. So clearly the skin got better. And this is looking at the skin score. In placebo, you can see it got a little bit better placebo response rate, but then it kind of leveled off during the trial. And these are the 2 treatment doses. You can see people got much better when they got the 2 treatment doses relative to placebo. So that about this is looking at the patients who had 50% improvement in their skin score when they had moderate to severe skin disease. So this is pretty encouraging. This is how well the drug worked. The interferon in the blood, the signature that would drive certain genes, goes all the way down with the when you get the antibody against the receptor, and then it comes back up again after the trial's over. So it's doing what it's supposed to do. And then they went on to a phase 3 trial that got published in the New England Journal, and this was about 2 years ago now. Hard to believe it's been 2 years. And what this is showing is that there were twice as many responders. So the group who got the drug, the anifrolumab, is in red here. And you can appreciate that twice as many people at 12 weeks, which was the endpoint for skin, got better relative to the placebo, where they didn't get the anifrolumab that blocked the type 1 interferon. And so this is, and it's complicated to do these phase 3 trials because they usually have to be really all over the world, and it's much harder to control who goes into the trial. And yet they were able to show a difference. And so this is very encouraging, and this led to the FDA approval for SLE. And so this is looking, again, over time at the skin response, and you can see that there's quite a difference here. And this is a 12-week time point, but there was a statistically important difference between those who got the drug and those who did not. So in terms of the plasmacytoid dendritic cells, that's a type of inflammatory cell, these nice little pink cells that are in the skin in a lupus patient. They make a lot of proteins that can drive the immune response. And so there's now a drug called, well, it's now got another name, but it was called BIB59. And so what that does, the antibody binds to BDCA2 and causes the receptor on the outside of the cell to go inside the cell, and they stop making a lot of the goodies that the PDCs make, like these different proteins and also the type 1 interferons, which we think are important in many patients with skin lupus. And so this drug has been tested in a phase 2 trial. Initially, this was their phase, actually early trial, where they only gave 1 dose of the drug sub-Q and here, and then they did a biopsy before they got that 1 drug. And then at week 4, 1 month later, 1 injection later, you can see that all these pink which was the type 1 interferon upregulated protein, when you get rid of the PDC, you get rid of that protein. And so these people got better. The armies are a responder, and their skin score went from 9 to 0. So you can see that many people got much better. Not everybody. Here's somebody in red who did not get better, and you can see that the pink didn't go away. And so what this is telling us is that this might be a really interesting approach with 1 injection to have such a big change in the skin is really quite remarkable. So they went on and did a phase 2 trial. And what you can see here is that the 2 doses of, or they did 3 doses of the medication in a 4-month trial, and the 3 doses, these 3 doses of the drug, the people in that part of the trial did much better in terms of their skin score than the people who got placebo. So this is very encouraging again, but showing over a longer period of time that people continued to get better and that the response was maintained. And so based on this data, there's now an ongoing phase 2 to phase 3 trial, a bigger trial that's just beginning, and there's going to be 1 in systemic lupus and 1 in cutaneous lupus. And so this is a very exciting time coming up because we really may have some new drugs that are going to be very effective and very easy to use. Now, this is another drug that has a very similar kind of mechanism to the previous one I just showed you with the BIB59 that caused the internalization of the BDCA2. This is an anti-PDC ILT7, and it depletes the dendritic cell, gets rid of it. So you can see this dendritic cell in brown here is gone after 3 months of injections. And you can see that protein, that MixA protein that was red on the other slide before is now brown, and it's gone again after the treatment for 3 months. And the inflammatory cells here are also gone here. So this is a very effective treatment for some patients. And you can see in the higher dose that this red curve suggests that the patients got much better relative to a lower dose than placebo. And you can see the time course for getting better. So already at 1 month, many of these people were getting better relative to the placebo group. So we have some very exciting sort of new approaches on the horizon. So we need to hold on to the therapies that we have. I think the one I told you about, the quinacrine, is a good example. We have a need for better therapies, and we have a lot of ability now to do more studies to try to understand why are there some people who get better with one treatment versus another, and we're doing work like that in our lab. We have an outcome measure that's working very well, and the Lupus Foundation has been very helpful in working to try to get the FDA to understand that the skin is really important. There are more options for therapeutically resistant people coming along. And there's a potential for new therapies that we've gone over just now, some of the newest and I think really important drugs that are being developed. So we need to allow drugs that work for skin and SLE to be used in cutaneous lupus. And that's a little bit of a hurdle with the insurance companies, because sometimes if it's approved for SLE, they may only allow the drug to be used for systemic lupus and not for the skin. And there's a need for studies that specifically develop new approaches for skin disease. So I think with that, I'm going to stop and entertain questions. And I guess, did you want me to start answering these questions, or do you want to ask me questions?
It's up to you. And we also have several questions in the Q&A, which some relate to some of these additional questions that we have. Some are separate. So let's start with these, and then we'll jump into the Q&A. We've got about 15 minutes left, so I think we've got time to cover several. So, and you have answered actually some of this, but I think one of the things that comes up is, at what point do you recommend somebody who may have some skin involvement to get from, if they're seeing a rheumatologist, to get to a dermatologist versus a primary care, and that interaction, and who mainly treats the skin involvement?
Right. So, each situation where people live is going to be different. And where I work in a derm department where, for instance, I'm an internist and a dermatologist, and we have a training program for people who train in medicine and dermatology and come out double boarded. And we feel very comfortable taking care of people who have lupus and have skin predominant disease. We work also very often with the rheumatology folks, as well as with nephrology. And so but there may be parts of the country where people are where there isn't a dermatologist who does that kind of thing. And you may end up wanting to find a doctor who in that community is the person who would take care of cutaneous lupus. But I would say at many major centers, the dermatologists are very capable to go through the treatment and evaluation that we just went through. And it really depends, I think, a lot on the whole referral network and who are the experts in your area.
And if somebody's looking for that dual board certified, such as yourself, what should they be looking for? Is there a certain term or something they should be asking when they call the dermatologist? Is there a way to research that? What should they be looking for?
Well, I think to be fair, I think there are a lot of people doing complex medical dermatology. There are a certain group of dermatologists that are doing more cosmetology. There's some that are surgeons, but there are, and I would say particularly in the academic centers, people who take care of complex medical dermatology. They do consults in the hospital, and they take care of really sick skin patients. Some of them are internists and dermatologists. Some of them are dermatologists, but who've done an excellent internship. And it's really more about what is the focus of a practice. And so to find people, for instance, we have a Rheum Derm Society, and they have a website, and you can find people that's their area of interest that are on that website, and you can find out, well, who is the Rheum Derm person in my community, or is there one? So and many of us we have our meeting actually in conjunction with the American College of Rheumatology, and we go to the Rheum meeting. So we are very I would say focused on the skin part of lupus. So that would be one place to look, is the Rheum Derm Society.
That's a great resource. Thank you. And somebody's going into a dermatologist for the first time with maybe new skin involvement or a new lupus or cutaneous lupus diagnosis. What questions should they be? What's some of the most important questions they should be asking about?
So, I mean, I think the first thing, it depends a little bit on, but you want to ask, is there anything going on systemically also? So, you would want to make sure your doctor is going to check some urine tests, some blood tests, and ask you about your history. Are you having chest pain? Are you having arthritis? So making sure about the systemic part of the disease. And then after that, you want to find out, what kind of treatments, I've gone through the treatments that are available, and you want to just say, what stage am I at in terms of what kind of treatments would make sense for me.
Great. We kind of answered this earlier when we were looking at the poll about SLE versus CLE. How common is the prevalence of both, or the separation of the two? Do you typically see in your practice?
Right. So, I mean, I think it's commonly said that about 70% of systemic lupus patients have some form of skin involvement. And so it's very frequent for people with systemic lupus to have skin. So the other way of looking at this is how many people with cutaneous lupus meet criteria for SLE. And, overall, maybe 20%. And a lot of people, some people may progress. And what we do is if somebody has cutaneous lupus, we do, depending on their other symptoms and what the blood tests are showing, we will still once a year check labs and a urine test to make sure that the disease hasn't progressed to more systemic disease. But a lot of people, 80%, don't progress. And in fact, if it's a localized disease, cutaneous lupus, maybe it's even 5%. So the risks are not that high for people who've had their cutaneous lupus a long time, but you still need to be monitored to make sure that nothing is changing.
Yeah, good point. When you talked about the nails and the UV light, and we know so many people who have issues with the sun, or in some very severe, UV light issues and things like that. But you mentioned the manicure light, which I thought was, oh my gosh, I would have never thought about that. Are there other normal types of lighting that we should be concerned about with protecting our skin against?
Sure. So it turns out that glass is pretty good at blocking UVB, but not UVA. And so, there are people who get, even like with a copy machine, there can be some, UVA that can cause problems. I've had patients who go to the dentist and maybe the light is not covered in a way and they get flares after getting dental work done. So those are the kinds of things to think about. And even going on a car ride, you're not going to get UVB if the windows are up, but you might get some UVA too, and still get some toxicity from that. So fluorescent lights, they can cause problems. There is some exposure there. So, it's good to be aware of, and not to be you don't want to be in the dark, but you just want to be aware of where the most exposures are. Usually if the light is far enough away, it's not going to cause problems.
And I think that goes right into our next question when you were talking about sunscreen and how important it is. And we always think of that in the summertime, but so the wintertime isn't often what we're thinking about. You run out for a few minutes, but even, I hear you saying every day, you think about, are you sitting in your car? Are you sitting in your window at work where you're getting natural light all day long, or even under a UV light? That sunscreen is just so important no matter where we are and what we do. That's
correct. And so you do want to be, careful. I would say you do want to wear it, but it's not going to be the same level of intensity of worry as you have in the summer. Yeah.
So talk to us more about what's happening in the research space. You have been so actively involved in research, which is incredible, and so needed. It is so exciting to see what's happening in the lupus space in general for research. Specifically in the skin lupus, are there other studies are there advances you see coming in the very near future that we should be on the lookout for? What's your predicament?
Yeah, I mean, I think we're at an amazing time. There's certainly lots of systemic lupus trials going on, but the idea of these phase 3 trials that are leading to approvals is really new. And now some of those phase 2 trials I was showing you are just really working beautifully. And it's an exciting time. We are doing quite a few trials. And I think that if your skin isn't doing well and you're frustrated or you're tired of the medications that are not working, then this is a good time to think about helping develop the next generation of medications that are going to be, I think, safer and better tolerated and more effective.
Yeah, we'll remind everybody to go to clinicaltrials.gov. You can actually access that off of our website, any of the Lupus organization chapter websites. If you just search research, and you'll have access to the clinicaltrial.gov and do some research on trials potentially in your area.
Right.
And I'm probably not going to say this next question right. Is Polypodium leucotomus extract helpful in protecting against UV rays in the way HelioCare does?
So yeah, I mean, so there are some suggestions that it can be helpful. It hasn't really been formally tested. There's like a case report of it working for photosensitive lupus. So I don't think we have enough data right now to be able to say for sure that it's actually, you know, what its effect will be. For polymorphous light eruption, which is another form of photosensitivity, it does seem to be helpful, and there were some pretty formal studies with that, but really there hasn't been so much done. So it's not going to probably hurt, but I can't promise you that it helps.
Yeah. How about treating alopecia? I know you mentioned that briefly earlier in your presentation. Is there something specific that you could point to for people who experience that?
So there are different forms of alopecia, and the first thing is to make sure that the alopecia is from lupus, because there are many causes. It can be medications, it can be telogen effluvium just from being sick, you know, not necessarily the lupus, and then there's a generalized kind of thinning of the hair, which can happen in systemic lupus, and usually if you can get systemic lupus under control, then the hair grows back. But if for the scarring or the discoid or forms of lupus, I think you want to treat it as aggressively as possible to try to minimize the inflammation and hair loss and all those. And sometimes the hair will not grow back. If it doesn't grow back, then, you know, I mean, if your disease becomes completely controlled, I mean, could a hair transplant be helpful? I mean, I'm sure there are people that do that, or to go to some kind of hair replacement in terms of, you know, a weave or, you know, a wig. I mean, those can be amazing. So there's no way though, once the scarring happens, to really get that hair to grow, because the follicle gets scarred and the hair can't get through.
Can a patient have both the mylar rash and the rosacea?
Yeah, that's a great question. Sometimes, you know, it can look a lot like lupus, and a lupus patient can get rosacea, and then it gets very confusing. But yes, you can have both. Definitely seen both. And sometimes you can't tell which one, and then a biopsy can be helpful because they look really different.
And what is the best treatment for chilblain lupus? Do you see pediatric patients with cutaneous lupus? Kind of a two-parter.
So yeah, so the chilblain's lupus is really not that different from regular lupus. We use antimalarials for that. And it's considered part of the chronic cutaneous lupus. So the treatment is pretty much, and also often worse in the winter time. So hand warmers, keep your hands warm, your feet warm. I mean, those are the usual things that we recommend. So with pediatric patients with cutaneous lupus, I think, you know, there is a subpopulation of dermatologists that are pediatric dermatologists, and they are typically, or a general dermatologist who sees children, are typically the people that might treat cutaneous lupus. And there's a group of pediatric dermatologists now who are specializing in lupus and autoimmune disease. So in the same way that I mentioned about the Med Derm Society, there are pediatric dermatologists that are doing the same thing.
Terrific. All right, let's see. We've got time for maybe one or two more questions before we wrap it up. Is anifrolumab used for scalp issues? I think you said you saw a good response in skin, but specifically scalp.
Yeah, I don't think we know that yet. I don't think it's actually been looked at that specifically. And as I mentioned, we don't really actually even know which subtype of lupus or how often it works for, say, discoid or subacute cutaneous lupus. So there's a lot yet to learn about anifrolumab. And I think we'll learn more as people become more able to use it now that it's been approved by the FDA.
Okay. And I think our final question here is, can chemical sunscreens be ineffective? I often get redness, rashes, even with use.
Yeah, I mean, it depends on how they're working. I mean, if the problem is that very often you said chemical sunscreens?
Yeah, so you know, the other than, I guess, a natural sunscreen.
Right, or we have the barrier sunscreens like the zinc oxides. Yeah, the chemical
Yeah.
sunscreens, they come in these different SPFs, and they're supposed to be used in a way that's using a fair amount of volume on a body surface area when you apply it. And I think people often put it on not sufficiently or not far enough ahead of time and don't reapply when you need to reapply it. If you've been in water. And so there are many reasons why it might not work. Or again, if you're sensitive more in the UVA range, the sunscreens don't really work quite as well there, the chemical sunscreens.
True. I do think we are all guilty of the application errors.
Yeah, you
You
really
miss
have
a
to use a
spot,
lot.
we do. You do have to use a lot. I think when you actually see how much you have to use, you're always surprised. So I think we need to wrap it up. We're just at about time, Dr. Worth. I can't thank you enough. I think we have learned so much tonight, and if nothing else, we have learned that not only is SLE as heterogeneous and as diverse among people living with lupus, that CLE is as diverse with so many different subtypes and challenges and everything else. And but extremely important information that we shared. So thank you for being with us tonight. Thank you all for joining the program. The recording will be available in the next few days, and you'll be able to access it through your chapter website. You will receive an evaluation for tonight's program, so we do appreciate you taking a moment to fill it out. We really do strive to improve our programming and bring new topics to you based on your feedback. So thank you in advance for helping us with that. And be sure to tune in next month on March 9th for the next Let's Talk About It, which will focus on lupus and employment issues in the workplace. So we'll see you then. Have a wonderful evening. Thank you again, Dr. Worth. Everybody stay safe, stay well, and stay warm if you're in the cold regions these days.
Great, thank you so much.